Welcome to Health Yeah, where experts from Stony Brook Medicine come together to discuss topics ranging from the complex inner workings of an infectious disease to tips and tricks for staying safe and healthy all year long.
Welcome to Health Yeah. I'm your host, Dr. Tara Houston, a plastic surgeon at Stony Brook Medicine. Today, I'm joined by two of my colleagues, Dr. Amna Sher and Dr. Jordan Slutsky, and we'll be discussing an important topic, skin cancer. Before we dive in, I'd like to give my guests a chance to introduce themselves. Dr. Sher, could you start by telling our audience a little bit about yourself?
Hi, everyone. I'm Dr. Amna Sher. I'm a medical oncologist, and I specialize in treating patients with skin cancer.
And Dr. Slutsky, would you mind introducing yourself as well?
Sure. I'm Dr. Jordan Slutsky. I am a dermatologist, but I practice dermatologic surgery and a specialty called Mohs surgery. So I specialize in removing and treating skin cancers.
Thank you both for joining me today. As the weather gets warmer, more people are spending time outdoors and enjoying the sunshine. Well, that's something many of us look forward to. It also brings an important health concern to mind: skin cancer. Skin cancer is the most common form of cancer in the United States, affecting millions of Americans each year. Among the different types of skin cancer, melanoma stands out. Although melanoma accounts for a relatively small percentage of all skin cancer cases, it is responsible for the majority of skin cancer-related deaths. It is also one of the fastest-growing cancers in the United States and one of the most common cancers affecting young adults. The good news is that while melanoma can be aggressive, it is highly treatable when detected early. In today's conversation, we'll discuss how skin cancer is detected, review current treatment options, and answer some of the most frequently asked questions about skin cancer and melanoma. Let's begin by explaining our roles in skin cancer and where we enter a patient's journey, and at what point a patient moves from one of us to the other. So, Dr. Slutsky, you're the front door.
Yes. So dermatologists, patients come to us. We do skin cancer screenings from head to toe, and we're looking for suspicious lesions to identify, biopsy, and potentially treat as needed.
And then when you find a suspicious lesion and you biopsy it and it turns out to be a skin cancer, you will either take care of it through Mohs that we'll talk about later, or if it needs a more extensive excision and potentially reconstruction, you'll send to a general surgeon, plastic surgeon such as myself, or a surgical oncologist. And then once I've removed the tumor, potentially check the lymph nodes, I will then send the patient to you in medical oncology, Dr. Sher.
Yes, so I would get involved whether a patient needs additional therapy for a high-risk melanoma or if the patient has advanced disease and need systemic therapy as their mainstay of treatment.
Great. So, Dr. Slutsky, from a dermatology point of view, what are the early signs and symptoms of the most common skin cancers that our viewers should know to look out for?
Sure. So the big three skin cancers that we worry about most, number one is basal cell carcinoma. Basal cell carcinoma often, in most skin cancer, doesn't present with any symptoms. So basal cell carcinoma can look like a pimple, for example. Squamous cell carcinoma, which is the second most common skin cancer, can look like a scaly bump. It can look like a rash. And then melanomas, of course, are the feared skin cancers. They often look like an atypical mole. But I typically counsel patients to look out for the ugly duckling lesion, the lesion that's either new, changing, or different than other lesions that they might have on the body, which are benign and not worrisome.
So back in high school health class, a lot of us, even before medical school, and a lot of our viewers learned about ABCDE
Yes.
to look for skin cancer. What is that? Can you explain it?
So it's a mnemonic for A stands for asymmetry. So if a lesion is not symmetrical, if you can't divide it in half. B is border irregularity. C is color variation. So lesions that have a homogeneous brown color, it's brown throughout, that's okay. But if they have multiple colors, blues, blacks, whites, that's concerning. D, diameter. Typically we worry about things that are larger than the head of a pencil eraser. I don't love that one because skin cancers can be very small. And E is very important. That's evolving or changing. So lesions that are doing that.
And are there certain body parts that men and women should worry more about?
Definitely. So The most common places to get skin cancer are those that see the sun, because sun ultraviolet radiation causes most skin cancers. So sun-exposed skin, the majority of the skin cancers that I treat are above the neck, but patients often forget about ears, backs of hands, shins, feet. Skin cancer can affect any body part. I treat nail lesions. I treat genitals as well, which is typically cancers that are not from the sun. But speaking specifically to melanoma, melanoma is most common on the back of men and on the legs of women.
And when should someone see their primary care doctor versus a dermatologist?
That's a good question. Primary care doctors, some family practitioners actually are trained in dermatology and do skin exams. Others are not as comfortable with the skin exam. Typically, if there are lesions of specific concern, seeing a dermatologist is a good idea.
Okay. And can you explain how removing a basal cell or squamous cell cancer is different than removing a melanoma?
Sure.
And when we might consider Mohs versus surgical excision?
So generally, with basal cell and squamous cell, the non-melanoma skin cancers, we're not as concerned by how far out we remove the skin cancers as long as we remove them completely. With melanoma, it's more of an insurance policy. So we tend to take wider margins because melanomas can behave more aggressively, and we want to make sure to clean up, potentially any cells that might have gotten away from the cancer.
Right. And we know with surgical excision, we can get our risk of local recurrence to as close as 0 as possible. And just to add on for the surgical excision, because you and I partner with this frequently, when a melanoma hits a certain depth, then we worry about lymph node spread. And that's the time in which that we will surgically check a lymph node to confirm that the melanoma has not spread.
Exactly.
So I think we can move on to discuss reconstruction a little bit, that again, Dr. Slutsky and I share. But at what point would you say a dermatologist is going to excise and close a skin cancer versus maybe I want to partner with a reconstructive or plastic surgeon on your case?
Sure. A lot of dermatologists are very comfortable with excisions. I have a specialization in skin cancer surgery, dermatologic Mohs surgery. So for low-risk skin cancers, ones that are small in diameter, that are low risk in microscopic behavior, that occur on the trunk and extremities, very often those are taken care of by a dermatologist in the office, either with excision, destructive methods where we scrape and burn or freeze them away. Sometimes we even use creams for more superficial non-melanoma variants. When we get into higher risk anatomy, so head and neck, if we get into skin cancers that are more aggressive and invasive, that's when we start talking about either Mohs surgery or treatment with surgical, plastic surgical, surgical oncology, general surgical specialties.
Great. Thank you.
You're welcome.
So one more question from the dermatology perspective, and then we're going to move on to Dr. Scher. What are the best prevention methods for skin cancer?
So the best thing to do is to, practice sun safety. So daily SPF, we recommend, the American Academy of Dermatology recommends an SPF of 30 or higher, all sun-exposed skin on a daily basis. We used to think that it was really only the ultraviolet B, the UVB light, that caused skin cancer. UVB is responsible for burning, but ultraviolet A is also responsible, and it penetrates cloud cover. It's present year-round. Of course, it's higher intensity in the summer and the more tropical climates, but we do recommend sun protection on a daily basis. Personally, I use a moisturizer with an SPF every day. And then if I'm going to be outside at the beach or on the boat or spending more time outside, a proper SPF, reapply every 2 hours, swimming, sweating, sun protective hats, sun protective clothing, sunglasses, and shade.
Exactly. Getting back to sunglasses, we know that melanoma doesn't just affect skin,
Yes.
but the eyes are anatomic risk for melanoma as well. So is there a special type of sunglass that you think patients should wear? And would you recommend it in both summer and winter?
That's a good question. Anything that their patients would be comfortable with and they're going to wear. Patients will often ask us what sunscreen we prefer, and it's really going to be the one that a patient likes cosmetically, that fits their budget. So as long as you're using some form of sun protection, I'm good with that.
Great. Thank you.
You're welcome.
So, Dr. Scher, when do you like to get involved as the medical oncologist? If surgery removes everything visible, including some lymph nodes, a patient might say, well, why do I need another doctor to oversee my whole body if the first two that I saw removed it?
Right. So, as I mentioned earlier, usually I would get involved when there is a patient with a high-risk melanoma. Even if they've removed all the cancer, the lymph nodes are negative, there are certain features in the pathology which puts the patient at high risk of recurrence. And the biggest thing is the thickness of the tumor. So if it's a thicker tumor, even without the lymph nodes, we know that giving additional therapy with immunotherapy has shown to decrease the risk of melanoma recurrence over 5 or 10 years. So that is generally when I would see a patient if surgery is done, lymph nodes are negative. And then in more advanced stages, if it's the lymph nodes are positive, the risk of recurrence is as high as sometimes 50 to 60% in stage 3B or C melanomas. And we have very strong data supporting that additional immunotherapy for a year decreases the risk of recurrence as well as the risk of cancer spreading over time. And lastly, I would get involved when the patient is unfortunately diagnosed with an advanced melanoma, which has already spread to other parts of the body.
Can you just take 1 minute to go back and discuss the staging for our listeners? You mentioned that the thickness of the tumor is one factor that's important to staging. But this is a concern for a lot of patients.
Sure. So, when we stage any tumor, particularly for melanoma, there are 3 different factors which we look at. The T is the tumor size, N is the presence or absence of lymph nodes, and M is the presence or absence of metastases. So in general, just to sum it up, stage 0 is in situ tumor. Stage 1 is a smaller tumor, less thick. Stage 2 is a thicker tumor between 2 to 3 millimeter without lymph nodes. And stage 3 melanoma is generally when, regardless of the thickness of the tumor, when the regional lymph nodes get involved with cancer. And stage 4 is when the cancer has spread to other parts of the body. For example, if it started on the back and it has spread to the liver or the lungs, that would be a stage 4 melanoma.
And would you say that fortunately most patients present with early stage 0 or 1 or 2 disease?
I think so. With the skin cancer screening, most of the patients are diagnosed with early stage disease, where even if it's a thicker tumor, lymph nodes are positive, we are able to cure the cancer with appropriate treatment with resection and lymph node evaluation.
Now, you talked about the first line of treatment that you give. You called it immunotherapy. So can you explain to our viewers what immunotherapy is and how it's different than chemotherapy,
Sure.
which a lot of people associate with cancer?
Sure. So immunotherapy has been around for melanoma for over a decade now. The first immunotherapy which was approved is ipilimumab, which was in 2011. And what it does is it's basically stimulating your immune cells to attack the cancer cells. In easy words, I explain the patients because there are various checkpoints in our body to prevent autoimmunity. So when we use these checkpoint blockers, they release the brakes on the T cells, and then those T cells cause directed cancer killing. There are several medications out there, such as pembrolizumab, nivolumab, but that is the main action of these and how they differ from chemotherapy.
Now, the term immunotherapy does sound a little kinder and gentler than the term chemotherapy, but there are significant side effects with these medications as well that patients need to be aware of.
Absolutely. I think in general, immunotherapy is very well tolerated compared to chemotherapy, but patients do need to be aware of some of the side effects which are very specific to this class of drugs. In general, people can experience some fatigue, skin rashes, but particular side effects of interest are what we call immune-mediated side effects, such as inflammation of the GI tract, colitis. It can cause pneumonitis, can cause alter the thyroid gland or the adrenal, and some of the rare toxicities such as cardiac or liver toxicities. They are not as common, but patients need to be aware of that as soon as they experience any of these side effects, they should promptly notify their provider.
And now I understand that my next question is going to be a difficult one. But patients ask this. They see the word melanoma on a pathology form. Dr. Slutsky finds it for them, and their first question is going to be, can I survive this? What will my life expectancy with this be? And I know it's improved significantly since 2011 when the immunotherapies were developed, but can you give some ideas of how much better life expectancy is now with early and even with advanced melanoma?
Sure. So, I think I'll start off with early, as we all know, with stage 0 or 1 melanoma. We generally in the hallmark we look at is 5-year survival. So which is a number of people who are alive at 5 years after their diagnosis. For stage 1, it's 99% or so. As we go into a little advanced stages, stage 2 is still over 95-97%. And moving on to advanced stage 4 melanoma, just to give a perspective, before immunotherapy, the median survival for stage 4 disease was about 6 to 9 months, which was obviously not that great. But since we've been starting using immunotherapy, the median survival for stage 4 disease is about 6 years, which is unprecedented. So I think with that, we might be looking at potentially curing some of these, later stage patients with these newer therapies.
Excellent. Thank you. Now, one question for everyone. Is there a myth about skin cancer that you would like to debunk? Dr. Slutsky.
Sure. So the myth I would like to debunk is that skin cancer only occurs in light-skinned individuals. It definitely occurs more frequently in lighter-skinned people with significant sun exposure. The risks are sun exposure over time, and the darker skin is protective, but it doesn't make you immune to skin cancer. So I treat patients that are Latino. I treat Black, African-American patients. I treat patients of every gender and ethnicity and age. So if there's one myth I would like to debunk is it can't happen to me. It can happen to anyone.
Excellent. Thank you. What about you, Dr. Scher?
I think I would say, people say when I'm out in a rainy day or a cloudy day, I don't need to wear sunscreen. I think that's not true because, even if it's cloudy, there are sun rays which can escape through the clouds and can still cause sun damage over time and increase the risk of developing skin cancer. So I think even if it's rain or shine, put your sunscreen on.
I have fights with my kids about that.
I'm sure. The myth that I'd like to debunk are tanning beds. Some people come in to my office and say, well, it's different than the rays from the sun, so it must be safer. I'm doing this indoor with lights. And it is absolutely not safer. It can almost double your risk for skin cancer later in life. Use of a tanning bed in your teens or your 20s. So I strongly discourage young people and older people from using tanning beds. Not only does it result in skin cancers, melanomas, it also ages your skin and gives you wrinkles. And we don't want any of that.
Definitely not.
And then my last question for both of you is, what is one thing that our listeners should start doing this week to protect themselves against skin cancer? Dr. Scher, you first.
I would say make sure you put on your sunscreen and put it, the proper way. And they should reapply every 2 hours, especially if they are, planning to be out in the sun for a longer period of time.
Dr. Slutsky.
Take a look at your skin. Go to a mirror, look at your body, if you have a partner or someone to help you with your back. But are there any lesions on your body that are worrisome, that are bleeding, that look different than your others? And just take stock of what's on your body.
But 2 excellent points. Thank you. And my suggestion this week is to call your local dermatologist and make an annual appointment. We go for our annual mammograms to check for breast cancer. We get our colonoscopies on time to find colon cancer early. And I think that a total body skin exam by a board-certified dermatologist should be part of our annual health workup. So I encourage people to make those appointments this week.
That's great advice.
So that's all the time we have today. Thank you to Dr. Scher and Dr. Slutsky for your time. And thank you to our viewers and listeners. If you found this conversation interesting, don't forget to like and subscribe for more informative health-related content. For more information, call Stony Brook Dermatology at 631-444-4200. Thank you.
Stony Brook Medicine is Long Island's premier academic medical center. We transform lives through scientific discovery, education, and care, and we bring together innovative research, advanced education, and extraordinary healthcare expertise to set the standard for how healthy communities thrive. For more information, visit stonybrookmedicine.edu or follow us on social media. Stony Brook Medicine on Instagram, Threads, Facebook, YouTube, and LinkedIn, and Stony Brook Med on X.